Welcome to the Pharmacy Quality Solutions Quality Corner Show, where we talk quality of healthcare and explore what that actually means. Let's dig into performance measurements, the equipped platform, pharmacy goals, and personal goals. We will also occasionally cover topical healthcare news and maybe throw into the conversation a few of our own nerdy passions and hobbies. So turn us up. The Quality Corner Show starts now.
Hello, Quality Corner Show listeners. This is your host, Nick Dorich, and we welcome you to episode 48 of the Quality Corner Show. Today, as in the day that this episode drops, will be October 20th, which is Pharmacy Technician Day. This day recognizes all the hardworking pharmacy technicians on the front lines in a year where everyone working in a pharmacy is considered to be an essential worker, at least in my mind. We already know that October is American Pharmacist Month, and it's an important recognition that the third Tuesday of October is devoted to the pharmacy technicians. Through my career as a pharmacist, every successful pharmacist has been clear to referencing their path to success. None of us can successfully operate our pharmacy services or improve patient care on our own. It really does take a team effort, and pharmacy technicians are increasingly utilized as a resource on the pharmacy and healthcare team. On this show, we've spoken extensively about the future we'd all like to see for pharmacy practice. Now, I've got a spoiler alert for our audience. The successful future for pharmacy isn't just about optimizing the role of the pharmacist. We also need to optimize the role for the pharmacy technician. To further explore the topic for this episode, we are excited to interview Alex J. Adams, Administrator, Division of Financial Management for the state of Idaho. Alex, welcome to the Quality Corner Show.
Thank you for having me, Nick. I'm excited to be here.
Before we continue further into this conversation, we need to know about our guest and why they are related to this topic. When I introduced Alex, our listeners will note that I didn't mention pharmacy at all. Alex, do you mind introducing yourself and explaining your career in pharmacy before we continue?
Well, sure. It actually starts before my birth. I like to say my dad, grandpa, and great-grandpa were all pharmacists. So as a fourth-generation pharmacist, I often joke my blood type is RX positive. I actually started my career as a pharmacy technician with Rite Aid in the early 2000s and went to pharmacy school and graduated from the University of Toledo. And shortly after graduation with my pharmacy degree, I ended up working for Pharmacy Trade Association in Washington, D.C., actually with their host, Nick. It was NACDS, which was the National Association of Chain Drugstores, but often at times we felt like we were working for the Northern Alabama Country Dance Society, but had quite a bit of fun doing so, and have and always will be a pharmacist, but appreciate the opportunity to work in a different field as well now.
Thanks, Alex. Appreciate that as far as your background. And I know we have a lot to cover, and you and I having prior experience working together, I know we could spend all day talking. So we're going to try to be very efficient, and we're going to talk about how pharmacy technicians can contribute to the future success of pharmacy practice. So without further ado, I'm going to go ahead and jump into our 3 questions for today. Alex, the first question I have is, through your career, even when you were a student pharmacist, you've been an advocate for expanding pharmacist scope of practice. Along with that, there has been a passion to expand the opportunity to pharmacy technicians. You already mentioned that a little bit in your introduction. What was the origination for this idea? And at the time, was there evidence available to show that this was realistic and that it would help improve patient care?
Yeah, well, Nick, I think you and I have chatted about this before, but my interest in this topic, I think, really started as I was heading into my last year of pharmacy school. And when I was in pharmacy school, it was before we had as many graduates going on to residencies as we do now, but it was certainly something that schools encouraged students to look into. And my university hosted a residency showcase where they brought in a bunch of the current PGY1 and PGY2 residents from the area and had them give us pep talks why we should consider pursuing residencies. And there was one I remember, I was struck by it. It was somebody whose primary argument that we should do residencies, it was that TechCheck tech would eventually eliminate pharmacist jobs. So I think maybe just to be a contrarian, I decided to start researching that topic, our final year pharmacy school, we had to do a seminar topic, which required finding peer-reviewed literature, synthesizing it, and presenting it objectively. So rather than do something about head-to-head comparisons about medications, I started looking into TechCheck Tech. And I found at the time there were 11 studies on TechCheck Tech. Some of them went back to 1978. So, 3 decades worth of research at that time. And in those 11 studies, techs performed product verification pretty much at the same level that pharmacists did. In none of those 11 studies did techs perform worse than pharmacists in terms of safety and accuracy. And in fact, in 6 of those 11 studies, technicians actually were more safe and more accurate than pharmacists in doing final product verification. And when you looked at the nitty-gritty details of the studies, I think my main conclusion was that the two have to go hand in hand. You can't elevate the role of the pharmacist without first elevating the role of the technician. Pharmacists simply won't have time to do the types of things that benefit star ratings. Pharmacists simply won't have time to do MTM, point of care tests, any of the value-added services that pharmacists can do if they're tied up doing rote, technical, non-discretionary tasks that studies demonstrate can be safely and effectively delegated to technicians. So, perhaps I started with the topic to become a contrarian, but I became a true believer. And, throughout the different phases of my career, from NACDS to running a board of pharmacy to where I am now, I think I've used each of those platforms in some way to elevate the role of the technician. And hopefully we'll be able to talk about some of those.
When this first started, Alex, what did you had mentioned 11 studies and some of the results that were there. Were there different groups that were working through this? Some of the criticisms I've heard with TechCheck Tech is that, that's meant for a hospital setting. But did you find that to be the case? And also, just so our audience confirms, I think most people now, most pharmacists are familiar, but do you mind explaining what exactly TechCheck Tech is versus maybe some of the, rumors that maybe what it's supposed to be like?
Yeah. So, if you think of when a pharmacist is filling a prescription, there's this whole front end clinical process where the pharmacist is making sure it's the right drug for the right patient, the right dose, and minimizes the chance of adverse events and interactions and all of that stuff. So there's the whole clinical component. After a prescription goes through the clinical battery, if you will, then it goes to the product verification. You pull the product off of the shelf, you put it in the bottle, and you make sure that the right product is in the bottle. TechCheck Tech focuses only on the second half of that equation. The first half is still a pharmacist clinical decision. TechCheck Tech's that back end, right drug in the right bottle. And at that time, all 11 studies were done in hospital settings. And kind of the thinking at that time was hospitals are different. Many of them already used barcode scanners, which weren't as prevalent in community pharmacies at that time. They used unit dose packaging, where each individual pill was in a specifically individually identified packet as opposed to a bulk bottle with 500 or so pills. The other thing is, in hospitals, drugs are generally administered by another health professional, such as a nurse. So even if the technician somehow botched it, there's at least a final step where another health professional is administering it, where there's another redundant check to ensure it's safe. So at that time, all those studies were done in hospitals. That it certainly changed since that time, in part because of the work you and I did at NACDS. But that's a brief overview of what it is.
Thanks, Alex. 2 items I'll point out quickly. Clinical aspects of care still managed by the pharmacist. And then, as you referenced, this is having the technician work on the item so that the pharmacist can really handle that clinical care. And when we talk about pulling this from hospital or health system settings, we need innovation to come from our partners. Maybe that's in pharmacy, maybe that's from other healthcare providers. So with that, I want to talk about Idaho and how you help drive this further. So it's getting into our second question, and we're fast forwarding now a couple of years. And you, Alex, are the executive director for the Board of Pharmacy in the state of Idaho. What occurred in Idaho related to how pharmacy technicians could operate to help part of the pharmacy team? And how did that build off of some of the earlier research and information that was already available?
I moved to Idaho in 2015. I came straight out of NACDS and made the move. Idaho's my wife's home. She was born in Blackfoot, Idaho. Went to Boise State and now teaches at Idaho State. So we do consider ourselves an Idaho family. And when I moved here, I started taking stock of where we were at and what some of the opportunities were. And it's a rural state. Perhaps not as rural as some think. I mean, Boise metro area is pretty large, but overall, we're 49th out of 50 in physicians per capita. So that really spoke to the opportunity that we had to have pharmacists fill some of the gaps in care that perhaps couldn't be filled based on where we were with physicians per capita. And we certainly chipped away at that. I'm proud to say Idaho is the first state where pharmacists can independently prescribe most medications, whether it's for minor conditions like flu or urinary tract infections or cold sores, or whether it's adding on care for patients with diabetes or hypertension. We're the first state where pharmacists can independently prescribe writ large. Our pharmacists can administer any medication, not just vaccines, but any medication, depot antipsychs, et cetera. They can order and interpret any test, not just CLIA wave test, and they can adapt prescriptions. And what I mean by adapting prescriptions, an Idaho pharmacist, if they get a prescription for something that doesn't come in that package size, can adapt it to a commercially available package size. They can adapt a quantity to help a patient get to a medication synchronization date. They can change capsules to liquids independently, and just all of those things that drive good patient care and help facilitate medication adherence. But in other states require the pharmacist to have to call a physician and wait 3 days for a response. So our pharmacists can practice a level that pharmacists can't in most states now. But like I said earlier, and like you said in your opening, in order to get the pharmacist there, they had to be untethered from those rote, technical, non-discretionary tasks that studies show technicians can do safely and effectively. So hand in hand with the advancement of the role of pharmacist, we also focused on enhancing the role of the technicians. But I think what made us unique is, and I know, Nick, when we were at NACDS, we listened to more boards of pharmacy meetings than we probably ever wanted to. You know, a lot of other states will start with, well, what should technicians do? And, you know, we started from a position of who should decide what technicians do, not what should they do. And, you know, kind of my starting point was we did town halls across the state, and we would have pharmacists say, I've got some incredible technicians who I would trust to do X, Y, and Z, but I've got some other technicians I wouldn't trust to do that. And it was very similar to interns. Certainly pharmacists will delegate a different level of task to a P1 than they do a P4 because, you know, they're at a different point in their education and training. Heck, at NACDS, Nick, we had some P4s I would delegate things to, and other P4s I wouldn't delegate anything to. We had a wide range of quality, but you as a pharmacist kind of have an internal barometer of what they're capable of, and you should retain that discretion in what you can delegate. So if we do that for interns, from a regulatory standpoint, our question was, why couldn't you do that for techs? So we set up a regulatory framework where pharmacists had the full latitude to use his or her discretion to delegate tasks to technicians as long as the task they delegated was within the education, training, and skill of the technician. So what that means in practice is that we have technicians all over the map. In some pharmacies, we have technicians who are administering vaccines. Pharmacist is still doing the clinical component of making sure it's the right vaccine for the patient, that there's no contraindications, and so on and so forth. But when it gets down to the technical task of sticking a needle in somebody's arm at a 45-degree angle, there's no reason that couldn't be delegated to a technician. And we have a couple hundred technicians who are doing that in Idaho today safely and effectively. And, you know, we're recording this in the middle of a global pandemic that will soon have a vaccine available. And think of how busy pharmacists are going to be when that vaccine for COVID becomes available. and how beneficial it's going to be to have all hands on deck and a pharmacist having technicians who are trained and competent to administer so that they can really divide and conquer. We were the first state to allow TechCheck tech in any practice setting, not just hospitals. We do have some community pharmacies using this. Some will kind of sprinkle. They'll do it on Mondays or the first day of a month when they're busiest, and that preserves the ability of the pharmacist to be fully available for counseling and some of those value-added services on those busy days. We have techs who are performing CLIA-waived tests, so pharmacists who are prescribing will have a tech go out and take a vital, and then depending on the result of that test, the pharmacist will make the clinical decision on whether or not to prescribe. We even have some technicians who are prescribing. That's probably my favorite. They're prescribing naloxone. So, in some states, they've dressed up naloxone with so much red tape where pharmacists have to do a training and have a protocol with a doc. They have technicians prescribing it. I mean, there's countries and provinces in Canada where naloxone is sold over the counter at gas stations. So, we think that a trained technician can certainly perform as well as an over-the-counter gas station counter. So in some ways, Idaho technicians have a scope of practice that I like to say is greater than pharmacists in some of the eastern states. It's something I'm pretty proud of, but I know sends chills down the spine of some pharmacists in those eastern states. But if you really go back to where it started, it was rural state, low physicians per capita, need for pharmacists to fill some of those gaps, which meant technicians had to be elevated in line.
And Alex, with the work in Idaho, this was setting up the regulatory framework or removing, barriers that were there and that may have existed. But you referenced it already. There was training that needed to be managed, and that training and education still needed to be implemented and still done at the discretion of the pharmacist or the pharmacist that was in charge. So it's not as if this was signed, passed across the desk, and immediately technicians were going and doing these services. I don't know if you have any other context to add to that, but the other component of it is just because something is updated from a regulatory or legislative standpoint, in many cases, payers will need to recognize or recognize that they will pay for that service. Did you deal with any barriers in that standpoint, or is that something that was left up to the individual businesses and their relationships with payers?
Yeah, I'll touch on both of those. From a training standpoint, you hit the nail on the head. A pharmacist can only delegate something to somebody if it's within their education, training, and experience. So if a technician can't demonstrate that they're trained to do immunizations, simply put, a pharmacist can't delegate it. But what we're seeing is the chains that have gone forward with this. Albertsons was the first chain. They rolled out a training that I believe was 6 hours in duration. And it was very hands-on, proper needle technique, how to draw vaccines, how to dispose needles properly, how to administer both subcutaneously and intramuscular. So there was a pretty hands-on training plus demonstration of proficiency. Then everything that's done by a technician is done under the supervision of a pharmacist. So there's quite a few checks and balances, and it's gone pretty safely. Now, to your point about we can remove from the Board of Pharmacy standpoint the regulatory red tape. That doesn't necessarily mean something will change in practice. In fact, oftentimes when you remove a hurdle, there's disappointment of how much something is taken up in practice. Yeah, that's because there's quite a few barriers, even outside of the law, to something taken off. Patient acceptance. Will patients accept it? Will they demand it from pharmacies? Payers. Will payers pay pharmacists for providing it? Liability insurance. Will your liability insurer for either you as an individual or for your corporation cover it? There's all these extra legal factors, as I call them, that can either facilitate or impede uptake. And in general, I think most states find that when you remove red tape, uptake lags, but usually it takes an event. So just like immunizations, I'll use that as an example. First state to allow immunizations in pharmacies, Washington State in 94. But very few immunizations were given in pharmacies. From 94 to 08, only about 5% of vaccines based on studies were given in pharmacies. In 09, H1N1 hits. Physician offices were inundated. Many of them were closed around the Christmas holidays when the immunization was finally readily available. So patients had to flock to pharmacies because it was the most accessible location. And after H1N1, 25% of vaccines now given in pharmacies. It's built into every school's curriculum. It's part of the accreditation standards. And I mean, find me a pharmacy that doesn't immunize in the community, and I submit that that's pharmacy that might not be around over the long arc of history. And sometimes there's inflection points that push things to the forefront, and COVID, I believe, is certainly going to be one of those.
Thanks, Alex. We'll move to our third question, and this has been in place now for several years. And how's it going in Idaho, right? You talked about what pharmacy technicians in Idaho can do and how that compares to some other states. But what's been the experience so far? What's been the feedback?
Yeah, so anytime a board of pharmacy talks about a regulation, the lens through which it's supposed to look is safety, just safety, not protection of the profession, anything like that. It's safety, safety, safety. And regulatory boards are often drawn to hyperbole. You do things in open public meeting, which means you take open public comments, and it won't surprise you to learn that there were safety concerns raised about all of these. And I kind of call it the bodies in the street phenomenon. You get people who come up and say, if techs can give vaccines, there's going to be bodies in the street. If techs can take verbal prescriptions, there's going to be bodies in the street. If techs can do final verification, there's going to be bodies in the street. So I'm proud to say that we have not been piling up bodies in the streets of Boise or any community in Idaho for that matter. 3 years in, it's gone pretty well. I'm not aware of a single safety issue. I'm not aware of complaints that have been lodged with the Board of Pharmacy alleging harm from technician duties. I'm not aware of civil cases alleging harm from technician cases. And I think that speaks to all those extra legal factors we talked about: patient acceptance and demand, payer acceptance, pharmacist willingness to delegate. Pharmacists are pretty type A people, as Nick, you and I have observed throughout our career. So I've always felt confidence in pharmacists' discretion in making the decision to delegate or not. So point blank, I'm not aware of any safety issues. Conversely, I'm aware of many examples of how expanded tech roles have freed up expanded pharmacist roles and how those have led to enhanced safety. I'll give you a couple examples. One, the very first day pharmacist prescribing went live in Idaho, we actually had the first prescription written that day. We had a tourist from Israel passing through Montpelier, Idaho, little town. I think there's a Butch Cassidy museum there, so maybe it was a Butch Cassidy fan. And passing through, developed a urinary tract infection. It's an international patient, insurance unlikely to work at the local emergency room. They stopped in the pharmacy asking for advice, and the pharmacist says, "Well, you're not going to believe this, but if I do a couple things to ascertain your diagnosis and whatnot," the pharmacist was able to prescribe the appropriate antibiotic in the store for that patient that day. And we've had dozens of those examples. We have a lot of resort towns. A lot of people pass through Idaho to go to Yellowstone. We have a lot of examples where pharmacists have been able to prescribe in the best interest of patient care, actually leading to better outcomes. One that's probably near and dear to you guys at PQS is there was a star rating related to what percentage of diabetics have a prescription for a statin. I've got a little dust in my pharmacy degree. So Nick, is that still a star rating? I don't know if that's still in the star rating.
Yes, still actively a star rating. Yes.
Outstanding. Well, then the story will be worthwhile. So pharmacists, again, in Idaho can prescribe a statin. If they identify a diabetic patient who is not on a statin, the pharmacist can go through a clinical consultation, make sure that they don't have any of the contraindications, and the pharmacist has the legal authority to just independently prescribe it. In most other states, if a pharmacist identifies a diabetic who's not on a statin, they basically send a fax to the doc making the case. And there's studies, I've seen some of these studies, where it basically takes about 10 phone calls of begging and pleading and cajoling the physician to try to add the statin. There's some actual evidence that would suggest the more you call, the less likely they are to prescribe the statin. It's like the more my wife tells me to pick up my clothes, the more likely I'm not to do it and try to rationalize why it's wiser for me not to do so. And you can probably imagine how that works out for me around the house. But the point is, are you really a healthcare provider if your main intervention is sending a fax to somebody else and being dependent on them to act? I would submit that you're probably not a healthcare provider at that point. So Idaho pharmacist providers have the ability to just close that gap, and it's a much more impactful solution. Why do pharmacists in Idaho have the time to do that? Because they're not chained to the rote, non-discretionary tasks. They have the ability to delegate those to pharmacy technicians. I'm proud that other states are taking note of what Idaho has done. I think it also comes with a dose of skepticism. Oh, Idaho's different. Idaho's just a rural state. That wouldn't work here. The practice of pharmacy is the practice of pharmacy. I mean, practicing pharmacy in Idaho isn't functionally much different than practicing pharmacy in Ohio, where I'm from originally, or in Virginia, where we lived for a couple of years, Nick. There's national accreditation standards for pharmacy schools. There's national licensure exams. There's nothing that would lead me to believe the practice of pharmacy in Idaho is functionally different than any other state in the country. And I certainly think some of the things we did are right for expansion.
Thanks, Alex, for that description. And I would agree. And the third question that I asked there, it's done with specific intention here at the end, wanting to know, well, is it working? You had referenced that there's always some friction or pushback for different items. And ultimately, if the results are positive for patient care, and if it's positive for the healthcare providers, but most importantly, again, if it's right for the patients, that's something that we should have and that we should expand. So you had referenced your phrase for those regulatory meetings. I prefer to think about it as far as a response. It can be very much a dogs and cats living together, mass hysteria type of situation. But that's not what the evidence is showing. The evidence is showing that it does work, and that ultimately what this does is that this changes the healthcare practice. It improves patient health outcomes. And those are parts that we should be welcome to address. Alex, I'm going to go ahead, and already did have a little bit of a fun in my last response there that I know you noted. I'm going to go to our closing. We always end it with a lighthearted question, and I can take this in many different directions, but I've got a great topic for us to explore. You were the 2015 Prescott Award winner, which recognizes a pharmacist that is within 10 years of graduating with their PharmD. You used that opportunity to formally announce and explore the topic of quote unquote permissionless innovation. Within pharmacy, we often talk about how we'd like pharmacists and pharmacy technicians to do more. You have the unique experience of being a pharmacist that has helped that become a reality in some degree. So how do we as a profession continue that work, and how do we continue to build upon this idea of permissionless innovation?
Sure. Well, first, I'll try to define permissionless innovation. It's really came out of George Mason's School of Economics. They have a scholar there, Adam Fear, who put forth the concept of permissionless innovation. It's just one of those phrases that I love, because it's the philosophy of allowing experimentation with new technologies and business models by default. And rather than going to a regulatory board and asking for permission to do everything, it has a permissive architecture. You can operate within that, but you're held accountable for your failures, and you're held accountable if you cause harm. And it was pretty impactful to me, because when I ran the board of pharmacy, it'd take us a year from start to finish to get through all the requisite steps to finalize a regulation. Every board in the country falls under a state administrative procedures act. We have to post notice and take comments, and it's a pretty slow and deliberate process to involve as much public participation as possible and ensure that good decisions are being made. But when you have a rapidly evolving field, and in many ways I consider pharmacy a rapidly evolving field, the technology that's available is rapidly evolving, from automated dispensing to drone delivery to artificial intelligence and whatnot. It's a rapidly evolving field. And if I was going to regulate for each of those things, we would always be playing catch up, and practice would always be a year behind because of how long it takes to do a rule. So permissionless innovation is figuring out a way to have a permissive architecture where people can operate within that, but be held accountable for their failures. And That's what Idaho really tried to go to. We've written a little bit about it. If anyone's interested, they're welcome to contact me, and I'm happy to send along some of those articles that describes our shift and how we did it and why we did it. But COVID was kind of the crystal clear example for me. COVID hit. We need pharmacists to be able to do emergency refills. We need them to be able to do COVID testing. We need them to be able to do COVID vaccines. Some drugs became in short supply, so we need pharmacists to be able to do therapeutic substitution. Many states realized that those things were absolutely needed to get through those early months of the pandemic and take some of the pressure off of traditional healthcare systems. So states across the country had to do gubernatorial-led executive orders. They had to do emergency meetings to remove some of that red tape. I was out here in Idaho drinking my Diet Coke. We had already created a permissive architecture that allowed each and every one of those things, and we didn't have to try to waive it. It was existing authority. Idaho pharmacists already had the ability to do those things. So emergencies, in many ways, kind of become inflection points in a profession. And Nick, we saw this after H1N1. I mean, you and I saw the rise of pharmacy-based vaccines right after H1N1, and that kind of sowed the seeds for pharmacy-based flu and strep testing as well. It invited public health professionals into seeing what the value of pharmacy was for perhaps the first time, and COVID's kind of doubling down on that. If you ask me, what's going to happen after COVID, there's going to be a sustained effort to try to make some of these things that were done through emergency orders long lasting. A pharmacist could do extensions of any medication by 30 days during COVID. Why couldn't they do it after COVID? The pharmacist could prescribe certain drugs during COVID. Why couldn't they do it after COVID? So, take these inflection points. I mean, when they come, oftentimes, it's like striking lightning and trying to bottle it. I think there's a major opportunity here for the pharmacy profession to bottle this lightning and, take a very grim situation like COVID and make it hopefully a good thing for the betterment of patients, for the betterment of public health over the long haul.
I couldn't agree more, Alex. And as you said it, if pharmacists can do this or pharmacy technicians can do this under an emergency guidance situation, why can't it be done when it's a normal or low pressure situation, right? When things are operating as they should. So I'm really pushing as I have conversations with other pharmacists and other pharmacy advocates. It's how do we make sure that we're able to show success with the opportunities that have been allowed because of COVID, and how do we transition those to long-term wins? Because ultimately, if the patient outcomes are improving because of these allowances, then it really shouldn't be a debate. It really should go to having pharmacists or pharmacy technicians have the permission to do this work. It's been a great conversation with you here, Alex, and it's great to hear from what has been going well in Idaho. I'll admit that I was perhaps for many years thought of Idaho for two things, that being potatoes and blue turf as the obvious choices. But now I'm happy to add with that the permissionless innovation for pharmacy practice. I do want to go ahead and close out for our conversation today. And Alex, we referenced it at the beginning. You're now working in a day-to-day role that's outside of just the pharmacy area, but I know that you're also happy to have these conversations, as you did today, about how pharmacy can work to improve patient outcomes or what else we can do to help pharmacists and pharmacy technicians. So if you don't mind sharing, is there a way that people can reach out to you if they have more questions about this topic?
Yeah, easiest is always just to find me on LinkedIn. I am cognizant that Alex Adams is a fairly common name in both genders. So add Nick Dorich first. And once you add Nick, it's a little easier to find me as a secondary degree connection on LinkedIn. But folks are always welcome to email me as well. It's alexadamsrph@gmail.com.
Great. Thank you, Alex, for being on today's show. I do also recommend you find Alex's remarks from the Prescott Award, which was referenced earlier. That's in the July 2015 issue of the Journal of the American Pharmacist Association. So be sure to check that out. Now, as we close, this was an important topic for me to cover on the Quality Corner show. We always recognize that quality improvement is the primary topic for this podcast. Just like the healthcare system as a whole does not recognize the true potential of utilizing a pharmacist, the pharmacy team also needs to consider how we optimize all members of the team, how we continue to educate ourselves and improve our process for our patients will be the ultimate benefit. how we ensure opportunities for all staff members, and so that a consistent service is provided will be key to our success. Pharmacists have a great opportunity to help improve patient health outcomes, but we cannot do it without the help of an optimized pharmacy technician workforce. With that, we're going to go out and close for today. And I again appreciate you listening to the Quality Corner Show. There is one final message from the PQS team. Our team here at PQS has a couple of favors to ask of you, our podcast listener. First, we encourage you to share this podcast with 2 friends, because if you share this with 2 friends and each of them shares it with 2 friends, it really helps us hit a larger listening audience. Second, we also want to take a moment to remind you to subscribe to the podcast wherever you may find it. And then, if you have any questions or topics you would like us to address, please contact us. The best way to do so is to email info@pharmacyquality.com. Let us know what is on your mind and what we can address so that you are fully informed. Our goal is to continuously improve our podcast content and to provide meaningful information to our listeners based on current topics in healthcare, technology, and quality measurement. We want to help you become as effective as possible in how you care for patients and improve public health outcomes. So until next time, we wish you well.